Can they hear us, Janice?
Yes.
Okay.
Hi, Janice. Steve's here.
Hi, Steve.
Can they hear us, Janice?
Yeah,
Yeah.
I couldn't get my iPad to work, so I'm here.
Okay. All right. So we have Dr. Fuller. Hi, Steve. Yeah.
Get my iPad to work, so I'm here.
All right. So we have Dr. Fuller. Steve.
Oh.
Okay, we have 69 participants on. Hello, everyone. I'm going to wait just a couple more minutes and allow a few more people to come online, and then we'll get started. For those of you who are online now, we're going to be using the Q&A and not the chat. If you have questions in addition to the ones that you've already sent to me, we're going to use the Q&A because it's easier to manage the questions that way. So if you put your questions in the chat, it may be a while before I see them, or I may miss them entirely. So try to put them in the Q&A. And for those of you who are not familiar with the webinar setup, you will be able to see a presentation. You will be able to put questions in the Q&A, but you will not be able to see each other. You will only be able to see the panelists and the moderators who are helping me with the questions. And you can chat between each other, but you cannot turn your microphones on either. Okay, welcome everyone. I'm so glad that you guys were able to come and visit with us today. And we have a special treat for you. We have Dr. Oveta Fuller here, and she's going to give a short presentation, and she will take questions after. And excuse me, I'm going to give you a little brief overview of Dr. Fuller's bio. So bear with me if it's, if you can't hear, you can raise your hand. You can hit the button and raise your hand if you cannot hear me. Oveta Fuller is an associate professor of microbiology and immunology in the medical school and faculty in the STEM initiative of the African Studies Center at the University of Michigan. She is an adjunct professor at Payne Theological Seminary and an ordained itinerant elder and former pastor of the African Methodist Episcopal Church. As a scientist who studies and teaches about viruses, a virologist, Dr. Fuller's laboratory team published research on herpes simplex and influenza viruses. She teaches U of M medical, graduate, dental, and undergraduate students about human virus pathogens. Current implementation research science with the trusted messenger intervention that she developed engages networks of religious leaders as gatekeepers in communities of Zambia, South Africa, and sites in the US for effective disease prevention. She teaches intensive courses at PTS, What Effective Clergy Should Know About HIV, AIDS, and Health Matters, What Effective Leaders Should Know, to Divinity graduate students from across the US. Her course, Global Impact of Microbes, Fieldwork, immerses U of M participants in global research field sites to learn of effective partnerships for advancing health. Dr. Fuller earned a BA of biology and a PhD of microbiology and in immunology from the University of North Carolina, Chapel Hill, and was a virology postdoctoral fellow at the University of Chicago. Her research support has included National Institutes of Health and National Science Foundation grants. She is a fellow of the Ford Foundation and the J. William Fulbright programs. She has received academic and numerous community awards and recognition of contributions. She is an inaugural alumni of the Ansbacher Women in Academic Leadership Program at the University of Michigan's Medical School. She serves as the Vaccine and Related Biological Products Advisory Committee. She serves on the Vaccine and Related Biological Products Advisory Committee that examines COVID-19 vaccines, authorization or approvals for Food and Drug Administration. And I'm going to stop there because I think that you kind of get the gist of her credentials, and I'm sure you're looking forward to hearing her presentation. And as I said, remember to put your questions in the Q&A, not the chat, and raise your hand if you're having a problem hearing, because I cannot turn your microphones on and I cannot see you. So thank you very much and welcome, Dr. Fuller.
Thank you so much. I appreciate this introduction and the opportunity to be a part of this evening of the Jim Dandy Ski Club. That's been around for quite a long time, so it's a very extraordinary pleasure to be hosted by you and to meet you and others, Ethel Revels and the AKAs and all the other participant groups. It is certainly an unusual time that we're in, and I think the more we know, the better we can navigate. So what I was asked to do is to talk about the impact of COVID-19 on African Americans. And then I'm sure that includes the vaccines, which is, of course, everybody's decision right now. So what I've done is prepared a short presentation, a presentation that gives you the background you need to know. And then we'll have hopefully plenty of time for questions and answers. So if I can get the technology to work, let's see if I can do this. That's always a scary moment, but let's see what happens if we do it. All right, but you can't see that yet, right? Because I didn't push, nope, you can't see it yet because I didn't push show screen. So let's try it all over again. All right, now you see the screen, but you don't see anything on it yet. Oh, what happened? My goodness, okay. All right, I closed it out, but I'll get it back. Now you see this, yes?
Yes.
All right, I think we're ready to roll. So again, we're talking about the impact of COVID-19 on African Americans. And this is also relevant to anyone, but because I was asked to do this by the Jim Dandy Ski Club, that is the title that they were given. I'm very, very grateful to be a part of this. And this is part of the work of the Trusted Messengers team, which can be reached at this email address. What we're going to do is talk a little bit about SARS and coronavirus and COVID-19, and then about the vaccines. And then we'll have time for questions and answers. So I like to give the takeaway before we begin in case something happens with anybody's internet, or it's a great way to learn from the beginning. These are pictures of actual coronavirus in an electron micrograph. These are the spikes that you hear so much about. So what I want you to take away tonight is that pandemics are a part of adaptable nature. Human, animals, and the environment come in contact, and they adapt to one another as the world was created from the very beginning. Secondly, for COVID-19 vaccine, which is something everybody has to consider around the globe right now, you must make an informed decision. For my money and for my expertise, a 65 to 95% effective vaccine in preventing COVID disease, even for a little while, is a key, makes COVID-19 vaccines a key tool in the global toolkit to manage this disease, COVID-19, and this pandemic. And then lastly, importantly, you must make and implement an infection prevention plan, whatever you do about the vaccine. What is the prevention plan? Using mask, distancing, not gathering, and hand washing. These are absolutely necessary until we are out of this pandemic, or until we have the level of coronavirus positive tests below 3%. So we expect and require and ask everyone to model the behavior that will help us all working together to come out of this and get into our new normal. So let's first take a look at some definitions so we all are on the same page. And if you know this, I apologize, but I just want to make sure everyone is clear. So coronaviruses are a huge family of viruses like rhinoviruses or flu viruses. Over 100 different viruses in different animal species. We had two major pandemics or epidemics before, SARS and MERS. SARS was in China and MERS is in in the Middle East. So SARS coronavirus 2 is the latest of these human pathogens that evolved out of animals into humans. And this is a natural process called zoonotic adaptation. We've had it before with swine flu or bird flu. So we now have 6 different viruses, 7 with SARS coronavirus 2 that have gone from the natural bat or animal habitat, some through other animals to humans, some straight to humans. So SARS coronavirus 2 is a coronavirus that has moved from animals into human. And it causes the disease COVID-19 or coronavirus infectious disease 2019. It was initially called the novel coronavirus, but its official name is SARS coronavirus 2. When it was declared a pandemic about a year ago by the World Health Organization, there were about less than 5,000 deaths worldwide known and about 118,000 cases. Now, here we are a year and several weeks later than that declaration, or about 18 months from the emergence of SARS out of bats to humans, to have over 2.9 million deaths around the world that we know about, and over 132 million confirmed cases. This shows you the high level of virus around the world, with the US and Brazil and some European countries having the most. And this is very important. This is a picture of coronavirus being put outside of an infected cell. So these are the products from one infected cell. And what I'm showing you is just a small portion of that cell. If the cell were here, it would be bigger than my screen. And so one infected cell produces hundreds, maybe even thousands of viruses. And so this is an actual colorized picture of coronavirus. And you'll see this is really important because a little infection can produce lots of virus. This virus is airborne, meaning that it isn't transmitted sexually, it isn't transmitted by blood, but it's transmitted by the air, so in talking. And here are 2 examples that I want to help you understand just how easily this virus goes from person to person. Here's a case that occurred back in March, that was documented back in March, where a skier, that might be kind of cool for Jim Danny Ski Club, went on a vacation from Singapore to France, not knowing that that he was asymptomatically infected. That person stayed for 1 weekend for 2 to 3 days in a chalet with 12 other people. From that, over 21 people were ultimately diagnosed with the same virus in 3 different countries, because this person breathed into the air, viruses being made in their body, and people who shared the air in that chalet breathed it in and ultimately took it back to other people in their countries. And you can see the dates when other people were diagnosed. So it's a very highly contagious virus where only one asymptomatic person can cause a huge issue. This is another example of how we know it was not only respiratory drops, but aerosolized. And I have a video that, if I can get it to play like I'm hoping, better explains this than words. So I'm going to try to put that up for you to see. But the bottom line is that it's a restaurant where there were different tables. These tables are all in the same air conditioning system. And the people in the red got infected from this one person who was asymptomatically infected. So let's see if we can make this happen. See how technology works for me today.
To do with keeping customers 6 feet apart. Some of it has to do with airflow. A recent study out of China showed how one customer with COVID-19 spread the disease to 9 others. But look at the pattern of infection. Some people seated at the diner's table and at the one in the front and behind were infected, but nobody at the table next to it was.
When a virus is caught up in an airstream, it has the potential to move much further than 6 feet.
Professor Kevin van den Wijmelenberg and 5 other researchers from the University of Oregon and University of California, Davis, are the authors of a paper focused on minimizing viral transmission in buildings.
Your team has a 3D model of how it may spread.
We created a conceptual visualization of how the aerosols may be spreading in that room with a fan that is simply recirculating the air. Whether it was an air conditioner or just a fan moving air, the visualization is really trying to articulate how the particles get caught up in the air and move around the space.
The team created a second animation for the same room, only with an open window.
You had less people turn red and get sick. What did opening a window do?
Right. So in this conceptual visualization, what we were seeing is that with increased outside air exchange through the open window, particles deposit more quickly and then also be exhausted from the airstream more quickly.
Fresh air, fewer infections.
I think we're all going to be considering our air systems in buildings much more seriously moving forward. And I think restaurateurs will be included in that scenario.
As for the outdoor dining, Professor Van Den Mellenberg says that is safer than any indoor plan. Omar Villafranca, CBS News, Dallas.
All right. So this is what we just saw, is the transmission allowed these people with this one asymptomatic person, no symptoms, didn't know they were putting virus out, to allow others to get infected in the airflow. And so these are videos that you can watch on your own when you look at the recording of this. This is the first one, but there are others here that are very relevant to where we are now as we open up. So what am I saying? With the respiratory spread of COVID-19, when we talk or breathe at an infected person where the virus is reproducing in the nasal passages and throat, the air you put out is full of viruses. The cells in the upper and lower respiratory tract are producing hundreds of viruses, as I showed you previously. They can travel in the air at least 6 feet and possibly more, depending on whether they're singing or hard breathing or talking or exercising or coughing or sneezing. These aerosols with virus go into the nasal passages and mouth of another person, where it also begins to replicate, and that person now becomes infected. The virus travels down the windpipe into the bronchi and the lungs. We can also get infected by touching things that other people have breathed on and touching our own face to transmit the virus to us. The time of exposure is very important. We know that people are quarantined for 14 days if they think they've been exposed, and here's why. So after the initial exposure, the virus usually shows up in symptoms somewhere between 4 and 8 days. But the critical piece is that virus shedding happens before the symptoms show up. So this means that people who are not going to have symptoms, asymptomatic, or even people who are pre-symptomatic, meaning they're infected, they're going to get sick, but they don't show it yet, can be around other folks shedding virus without knowing it and thus spreading the virus. The symptoms that show up around day 5 are fever, headache, cough, loss of taste and smell, very common, shortness of breath, muscle pain, fatigue. Now, all of these show up in everyone. There's clinical infection, which can lead to COVID-19 symptoms and disease, mild, moderate, or severe. And then there's subclinical or asymptomatic infection, where there's absolutely no symptoms, but the person is still putting virus into the air. A reason this virus is so contagious. All right, what happens after the initial infection and symptoms begin in the back of the throat or with a dry cough, if there are going to be symptoms? It travels down the windpipe. It reproduces on the mucosal lining of the upper and lower respiratory tract, and that elicits an immune response. Our wonderful, fearfully made human bodies have a natural defense that whenever anything foreign gets in, we recognize it and begin to get rid of it. And so there's a war going on between the virus trying to reproduce and the immune system trying to shut it down. This results in about 80% of people who get infected having mild to moderate symptoms, and about 20% of people who get infected with symptoms having severe disease. What's severe disease? Well, that's what SARS is, severe acute respiratory syndrome caused by COVID or COVID-19 caused by the SARS coronavirus. What happens is once the virus gets into these bronchi, these are in a healthy person are are air sacs that have very thin membranes that allow exchange of oxygen and CO2. But when the person is infected, the replication of the virus in cells causes inflammation and death of these cells and just a mucus clogging that decreases and reduces and even stops airflow. The inflammation over time can lead to fluid buildup in these alveoli and these bronchi, such that a person ends up with pneumonia, which is fluid collected in the lungs compared to a very clear lung. So the impaired lung function from the mucus and cell damage from the virus restricts oxygen, which then affects all the major organs, or can affect many major organs: the liver, the kidneys, the brain, the heart, the skin. This is severe COVID. We also still have mild and moderate COVID where people have difficulty breathing. There are a wide range of body effects with COVID-19. It's, as someone said, this virus does not play nice. It really causes some very severe issues. The milder ones being pink eye and loss of smell and taste, the more severe ones being strokes, blood clots, neurological issues, lungs that cannot breathe and embolisms, heart attacks, arrhythmias because of clotting, kidney damage, which not only affects people immediately, but can be with people for a very long time, COVID toes or fingers where there's a purple rash. The immune system can be affected, GI tract issues with vomiting and diarrhea, and blood clotting, as you've heard. For the more severe cases, at least early on, they were treated on a ventilator or whatever it took to support the person to make sure that we could get oxygen into the body to allow the organs to function. And so whether a person survived or not depended on whether there could be enough support to help them through this very difficult time. Even people who get mild COVID now have what many find have long hauler syndrome, which is where instead of getting over it in a few weeks and feeling like themselves, there are long-term symptoms. This is brain fog, forgetting things, difficulty thinking, shortness of breath, heart arrhythmias, hypertension, your heart's beating really fast, joint pains, fatigue. So all of these are things that some people who get infected have for a very long time. And even some people who recover from COVID still have some of these symptoms. We do not understand how these work. There are lots of questions about what is long hauler syndrome and how does COVID-19 infection lead to the disease symptoms that we see. This session is entitled Impact on African Americans. So I wanted to be sure you understood that now, as of April 7th, in the USA, which is leading in the total number of deaths in the world, we have over 30 million reported cases, which means there's probably more, and over 500,000 deaths from COVID-19. As of today or yesterday, we have 175 million vaccine doses given out, with at least 66 million people in the US vaccinated fully. So this shows you US compared to others. And this is what has happened with COVID and African Americans. It has unveiled the disease disparities for many other things that also apply to COVID-19. So let's just look at Michigan. This side shows you the population of African Americans in the area, Michigan or Chicago or Louisiana. And then the right side shows you the number of deaths early on in May that were found in African Americans who died of COVID. So the number of the 100% of COVID cases, 41% in Michigan who died were African Americans, or 70% by May in Louisiana, or 67% in Chicago were African Americans, very disproportionate to the population. And now we know that overall the death rate is 4 times higher for African Americans than for whites in America. And so this shows you one specific site in Chicago where we look across Latinx, Black, white, Asian, and others for cases, as well as deaths. And you see that the African Americans have the highest levels of deaths and cases. And why is this? Well, there are a lot of reasons, and we don't have time to go into that tonight. But our frontline jobs, our medical conditions, our access to medical care, misinformation, and the historic systemic and institutional racism that comes with the health system here. And we can talk at some other point. I'd love to come back and talk about what we can do about these. All right, So what do we do to prevent infection and disease by coronavirus or SARS coronavirus 2? We know these well: physical distance, stay home if you don't have to be out, limit the size of gatherings, correctly wear a mask if you are away from home, even if you are vaccinated, frequent hand washing so we don't contaminate ourselves or inoculate ourselves from touching something, and get tested if you think you've been around someone who might have been infected. Agree or work with contact tracing and isolation. And then lastly, what we're going to talk about now are the vaccines and antivirals, particularly vaccines. This just simply shows you we're trying to keep anything that a person might have asymptomatically or not knowing. With the mask, these don't go into the air. And there's several different kinds of masks. All of them are reasonably effective. And this is how not to wear a mask. You want to make sure your nose and your mouth are covered at all times. It's not good enough to come into a room and have the mask on and let it drop 5 minutes after you've been talking to someone. So this is how not to wear the mask to prevent these droplets from going into the air in case you are infected. It also gives some protection for the people in the room if they have a mask on to keep droplets and respiratory aerosols from getting in. So what about these vaccines? Vaccines have been around for ages. This is one of our local newscasters getting her vaccine. So what are vaccines? They prime the immune system. You have to get them before you see the disease or you see the agent. We have plenty of these. Smallpox has been eradicated because of a vaccine. Yellow fever, we all got measles, mumps, rubella required before we could go to school. Some of us got a polio vaccine. We're getting chickenpox and shingles vaccines or pneumococcus. There's now one for cervical carcinoma with human papillomavirus. There's even an Ebola vaccine. And now we have COVID-19 vaccines. All of them have to be evaluated for their effectiveness or efficacy and their safety. You have to have them before you get infected, with only a few exceptions, say for rabies, where you can get it after you've been exposed. What form? It can be a live weakened virus, it can be a killed virus, or it can be a subunit, which is what the COVID-19 vaccines are. How often do you give them to the person? For most of the coronavirus ones, there are 2 doses. How do we store them? How do we measure response? How do we distribute them? We want high uptake so we can reach a herd immunity that allows people who cannot get vaccines to be protected, because so many people in the population are immune either due to vaccine or having had disease. Does it prevent disease? Does it prevent transmission? These are all questions when it comes to vaccines. With influenza vaccines, which we get every year, we get a 70% effective vaccine. We are really happy. We say that's a really, really good flu vaccine. With the COVID-19 vaccines, we're putting in not the whole virus, so it's not a weakened live virus. It's a subunit vaccine where we're only either putting in the RNA, the genetic material that makes these spikes, such that the spikes can be responded to by the immune system. And that's what I'm going to explain here. So we have now a number of vaccines that are in clinical trials, with 3 that have been approved for use in the USA. The Pfizer BioNTech, the Moderna, both messenger RNA vaccines, and the Johnson & Johnson, which was most recently approved the end of February, which is a virus carrier vaccine, a little bit different. But all of them allow us to express the COVID spike in cells so that we can make a response to them. And so here's another video, if I can get it to work. Let's see. I don't know why it's not doing it. Interesting. I don't know why that is. Let me try it this way. Okay, well, it was working before we got started. So I'll just explain this in another way. What we are putting into the person is not the virus. It is a messenger RNA that's in a fat droplet. And I'll show you this in a minute. What we're doing, all of these vaccines, all of them, the Pfizer, the Moderna, the Johnson & Johnson, have gone through the normal studies that occur for approving drugs and vaccines. And so the FDA approval process has not been skipped in any way for efficacy and safety of these vaccines. Materials go through preclinical laboratory studies, and you see the numbers, at least the last time I checked, that were in the various phases going up to approval. Phase 1 is where we look at safety in a small number of people. Phase 2 is where we looked at, are they working? Do they do what we want them to do in a larger number of people? That usually happens over a 24 months or so. Then the large phase 3 is what you've heard about, where there are thousands of people. In these studies for Moderna and Pfizer, there were over 40,000 people in those studies, 30,000 in one and over 40 in the other. And then when they get the data that shows that both safety and efficacy seem to be occurring in the thousands of people, they go for FDA approval, which is where the FDA reviews them. And then there's an advisory board of scientists like me. These vaccines have what's called emergency use authorization. There are 3 of them that have gone through the process after they did their high-level safety and efficacy studies. For Pfizer and Moderna, they had 30,000 people, over 30,000 people enrolled. And because we did not have the luxury of all the time of 5 years, we had to have more than 3,000 people. We had to have 30,000 people for 4 months versus 3,000 for 5 years. And because this is a single dose vaccine, we had to have even more for the Johnson & Johnson. All 3 of them were reviewed and went into what's now called emergency use authorization, and they're still under surveillance. They're still being collected. Data is still being collected. At some point, they will apply for licensing, but they are not yet licensed. They're just approved for emergency use because we are in a crisis. The Johnson & Johnson vaccine is an empty carrier virus that carries the spike protein gene into our arms and delivers it to our cells. So our own cells make the spike protein and our immune system can mount a response. There's only 1 dose required of it, whereas there are 2 doses required of Moderna and Pfizer to get up to the high levels of protection. So here's a summary of the vaccines, and both Pfizer and Moderna are messenger RNA vaccines. They have the spike binding protein made in our own cells because the messenger RNA is taken in a lipid droplet. They take 2 injections. For Pfizer, it's 21 days apart. For Moderna, it's 28 days apart. This gets us up to 94 to 95% effectiveness in blocking disease after both doses. After 1 dose, we're somewhere around 50, 60% effective. The second kind of vaccine is the virus vector, which is the Janssen or Johnson & Johnson. Janssen is the brand, Johnson & Johnson is the company. That's somewhere between 67 and 85% effective in blocking disease with 1 dose. It also works very well against current virus mutants. It was tested all over the world, in South America, in Africa, and Europe, and the USA. All of these give side effects because they activate the immune response against the spike protein, which is what we're putting in. We don't know yet if they block virus infection or shedding. So those studies are underway, nor do we know how long the immune duration lasts. When you get the vaccine, you will be asked to sit for 15 minutes to make sure there's no adverse reaction or immediate allergies. Then you're asked to register with VSafe on your phone so that you can get each day a survey to say, how are you doing? What effects or side effects are you seeing? If something really serious happens, you report it to this place, VAERS, which is the Vaccine Adverse Events Reporting System. And what makes me more comfortable with these vaccines now is that after millions have been rolled out, we're still seeing the same things we saw in the clinical trials as far as side effects. And those are listed here. So pain at the site of injection for maybe 2 to 3 days. All of these side effects are short-lived for 2 days, at 3 at the most. A headache, a fever, possibly a fatigue, being really tired, chills and sweats, muscles and joint pain, and severe side effects are rare and only temporary. So we see those with Pfizer and Moderna, and we could also add the Johnson & Johnson here. The good news is that when you have these, it means your immune system is doing what it should be doing, and they go away within 2 or 3 days. It's almost, people wake up and there are no symptoms on the 3rd day. It's pretty amazing. Here's a summary comparing the Pfizer and Moderna vaccines. They're both 2 doses. They're both messenger RNA in a lipid vessel. I'll show you that slide in a minute. They're both effective against multiple genders and races, up to 95% effective. One, Pfizer goes down to age 16, Moderna age 18, 28 days apart for Moderna, 21 for Pfizer. In order to have this work, in order to have us build up enough immunity for herd immunity to shut down the pandemic, we have to have people take these. So we need to build trust. We need transparency. We need clear messages. We need trusted people like this Jim Dandy ski club to bring information, people like me. We need access. We need equitable access. The places that have had the most disease need the most vaccine. We need community engagement and investment. If we get these things, we can build trust. We can set up specific host memory so that when the virus comes, we're prepared. And so this is a slide that was supposed to be a summary, but since I could not get the video to work, I'm going to share with you what's in the messenger RNA vaccines, the Pfizer and Moderna vaccine. So remember, we're trying to get this spike presented to our wonderfully, fearfully made host immune system. And so the messenger RNA, not the DNA, but just the little code for the spike only, is put into a lipid drop, a fat drop called a nanoparticle, lipid nanoparticle. So it's like the oil that we use for cooking. And inside that is a piece of genetic code, not DNA, RNA. You remember the DNA to RNA to protein from the central dogma. That is dehydrated in the vial. It is taken to wherever it needs to be used and reconstituted with water, a little bit of sugar, and a few buffers. There are no antibiotics, no preservatives, no adjuvants. That then is injected into our arms. And when that happens, that fat droplet is taken up by the cells. And because it has this material that's the code for making the spike, it uses our own cell machinery to make spike protein from SARS and put it on our cells. Now, because this is foreign to us, our wonderful immune system says, oh, this is not me. I need to combat this thing. And so we may end up making an immune response, both memory and antibody response to this foreign item, such that when we see it again, our immune system says, that's not me. I'm already prepared for it. I'm going to knock it out. So these are messenger RNA because they have messenger RNA from the spike protein in a lipid droplet. A great thing about this is that we can easily change the sequence to match whatever is circulating. So these types of vaccines give us lots of flexibility. So in summary, what have I told you? COVID-19 vaccines block disease and death. These are the symptoms that were used to evaluate whether the vaccines were working. People who had the vaccines did not get these symptoms of COVID. People who got the vaccine had no or mild symptoms, and there was no severe illness or death compared to people who got the placebo or the sugar water. So COVID-19 vaccines, all 3 of them, prevent disease symptoms, and importantly, they prevent illness and death. The vaccine effect on shedding and how long they last are still under investigation. And even when we get a vaccine, we need to use the public health measures. If you have these symptoms with or without a vaccine, you should actually seek emergency care. So we are in this together. These vaccines help us to do what we need to do to prevent illness and death. And I'm going to stop there, and hopefully this will be useful. I'm sorry the second video did not work, but hopefully that gives you an idea of what messenger RNA vaccines are, what COVID-19 is as a disease, how it leads to very severe issues that can lead to death or lead to long haulers that can change lives. And that's what we want to stop. All right. Are you there, Janice?
Yes, I'm here.
Did I put you to sleep?
No, you didn't.
So let's talk. Let's talk about this.
Okay, I'm going to take 1 second to do what I did not do in the beginning. I just came on and I started talking. I didn't introduce myself. I'm Janice Jackson. I'm the president of the Jim Dandy Ski Club, and we are hosting this seminar. And I am going to read off some questions, and Dr. Fuller will respond to them as we go along.
I will try to keep my answers short so we can get as many as possible. If you could come on so I can be talking to somebody, that would be really great. Thank you.
Okay. Okay, I didn't want to be a distraction while you were presenting. Okay, well, we have a question. Should we have extensive dental work, which includes injections and antibiotics, before or after the vaccine?
Yes, so dental work has been particularly vulnerable because obviously you have your mouth open and there are lots of fumes and aerosols generated. We spoke with the dentist in one of my classes recently. The answer to that question is I would wait until after I get the vaccine and get fully covered, which is 2 weeks after the second vaccine, before I had the dental work, unless it was an emergency. I've had cleaning. I had a crown that came off while I was over the last few weeks, but I was fully vaccinated and I went in and everything seemed to be very well done. There were not people in the waiting room. All the precautions that you want were there. So I would say wait until after you get a vaccine if you can.
Okay. Is there a unique benefit of the newest Johnson & Johnson vaccine over the existing ones?
What we're telling people is that you should get whatever vaccine you can most easily get. So is there an advantage of J&J? It's one dose. So some people don't like injections. And so one dose is, you only have to do it once. It is high in its effectiveness. And the J&J has been shown to block disease from some of the variants that are circulating very well. Even Moderna and Pfizer, the messenger RNA vaccines, also seem to work against these variants, but the J&J seems to be particularly strong. All of them are highly effective in blocking severe disease and death. As a matter of fact, J&J, Moderna, and Pfizer all block deaths to 100%. So they're pretty similar viruses. Vaccines. You have to decide what's available. I would get the first that's available.
Okay. What is the long-term effect of taking the vaccine?
That's a great question that I wish I knew the answer to. It's a question that's in the back of my head as well. It was a question that I asked at the FDA panel, along with how long does immunity last? And is infection stopped by the vaccine? There is no way for us to know at the moment the long-term effects of the COVID-19 vaccines. But you know what? That's true with so many drugs, so many vaccines that we get, because at the time that we get them, we know that nothing shows up within several months of the injection, but we don't know at the time that we get them what's going to happen. And so that's where we are with the COVID-19 vaccines. I wonder, but when I had to go get my injections, I got Pfizer. I took a deep breath and said, well, I know what COVID does. I know COVID-19 can lead to very serious issues in me, or possibly if I'm asymptomatically infected to someone I might give virus to. And so the known entity, the known danger, the very known danger is COVID-19. The one thing I don't know about the vaccines is what they do in the long term. And I'm going to have to take a step of faith, and I'm a person of faith, to say I'd rather be protected from this danger that's very real in front of me and others, and not worry about the long-term thing. And that's what I did. And that's what I would encourage other people to do. We don't know, we won't know until we're 3 to 5 years out. But with other vaccines, we have not had any issues. And there's no reason that I can think of, or other scientists, that this particular vaccine will be any different.
What is the likelihood that the COVID vaccine will become an annual suggested inoculation, similar to the flu shot?
Well, I don't know if it's going to be annual or how frequently, but my guess is that we will be getting boosters or a periodic shot or injection or vaccine against coronavirus. And that is because, as I showed you earlier, the virus is able to come from animals to humans. And then once it's reproducing in humans, it continues to adapt, because every time it reproduces, there are mistakes made. If that mistake, that's just how it works. It's reproducing messenger RNA. and there's no way to fix it. If that mistake is good for the virus, most of those mistakes don't make the virus, are not good for the virus. But those that make the virus more fit, Janice, you remember the survival of the fittest that you learned somewhere in biology?
Yes.
Long time ago, right? So if the variation makes the virus more fit for transmitting, that variation is going to rise to the top of the pack, and that's what's going to be circulating. And that's exactly what we see now with the Great Britain or the B117 variant that's actually in Michigan right now and changing our demographics, our infection demographics.
Okay. I have a couple of questions explain how the COVID-19 works, but I believe that was covered in your presentation. So let me move on to another.
And I'm sorry that video didn't work. I don't know what happened there. I may go back and try to play with that. And if we have time, actually play it for you.
Okay. Okay. How long do you have to wait after the second dose of Pfizer and or Moderna to be totally protected?
So the idea is that within about 2 weeks or 14 days after the second vaccine, you're considered fully protected. So about 2 weeks after the second one. And actually, if I may elaborate here, there are people who have gotten the vaccine, gotten the first dose, then they get exposed and they get COVID and they say, oh, I got COVID from the vaccine. And that's not true. You can't get COVID from the vaccine. There's no virus there. There's only that little tiny spike protein. And let me give you this analogy that I think helps people. If my fist is the virus with all my fingers, and my thumb is that spike attachment protein, which allows the virus to attach to a cell so it can get in and make more virus. When we do the Moderna and Pfizer vaccines and the Johnson & Johnson, we're only putting in the little thumb, the code for the thumb. So we're not putting in the whole virus. So there's no way you can get COVID-19 from the vaccine. What is happening when people get vaccinated, and if they're within 14 days or less of the time from exposure from the vaccine, when the exposure happens, they're still very vulnerable to virus replicating. And I have a couple of people that's happened to, where they got vaccinated. One was 10 days out, and he actually was a DJ at a party with over 200 people, and he got COVID. But you know what? His COVID was not severe. He felt bad. He had horrible congestion, but he didn't have to go to the hospital. And it was over in like 5 days. He took a whole bunch of vitamin D and vitamin C and other things. So I think the partial vaccinated system helped him, because you imagine if you're around 200 or more people, some masked and some not, at an event with DJ for several hours, you're going to get exposed to a lot of virus. So I think he just was very fortunate. My point is that you're not protected until at least the second dose, 14 days after, with Moderna and with Pfizer, and at least 14 to 21 days with J&J. And we're told with Johnson & Johnson, the protection even gets higher 4 to 6 weeks out.
Okay. How does that happen? How does it get higher?
Because your immune system is still building. It's still building its potential. It's like a snowball for skiers, right? you start out with the snow, with the little ball, and as it gets going uphill or downhill, it gains momentum. And so the immune system does that a bit until it reaches its maximum. So it's kind of like that. It's what we're told with Johnson & Johnson.
Okay. And okay, this person says, when I received the first vaccine, Pfizer, I was sick for 2 days with almost every side effect listed. Especially troublesome were the headaches and chills.
Mm-hmm.
Can I expect a reoccurrence of all that when I get the second shot? Is there anything I can do to lessen the side effects?
Yeah, so obviously this is a female, and what probably seems to be happening, this is me saying this, is I think young young females, a reproductive age, have the more likely severe effects. I don't know if that's true, but that's what I've seen myself in people I've talked with. And so we know from the clinical studies that the second injection tends to cause more severe side effects or more pronounced side effects. And here's why, Janice. The first one gives your body some immunity. It says, I've seen this. I see this spike. I'm going to make antibodies and T cells to it. And so you have that. Then when you see it again, your body already says, oh, I know that. I'm going to duke it out with that. And it sort of increases its response, which then, of course, increases what you feel, because those side effects are the result of a healthy immune system doing what it's supposed to do. And what it's supposed to do is fight against anything that's not you or me. So unfortunately for that person, not really unfortunately, but fortunately, if she has a healthy immune system, she may get more robust side effects the second time that typically go away still within 2 or 3 days. And what can she do to stop it or to reduce it? We are asked not to take any anti-inflammatory Tylenol, Advil, aspirin before you get the vaccine, because that may tap down your immune system. But anytime after 3 to 4 hours post-injection, because the material has already gone in your body, your immune system is already going, it's okay to take some Advil or some Tylenol or something to help reduce the fever and body aches and that sort of thing. And so I also recommend that people are fully hydrated. Be sure you've had lots of water and that you don't get your vaccine on an empty stomach. I know some of us do intermittent fasting. So, in the mornings, we don't eat till midday. But, the day you get your vaccine, be sure you've had a meal. The other thing that I've heard works and I've done is when you get it, massage your arm where the vaccine goes in and be sure you circulate. Probably one of the things you don't want to do is lay down and sleep the rest of the day. But keep your blood flowing so that things get put all over your body and the vaccine doesn't accumulate in one spot, which makes the immune response accumulate there. So those are just some side notes that can help a person navigate this vaccine time. But again, the side effects are short-lived. Even the next week, I felt a little tired more than usual, but then it was done. And I have this wonderful protection, which makes me feel a lot better, even though I still mask up. I'm like, oh, I can actually go to the grocery store and not, hold my breath. Or I can get together with my fully vaccinated pastor and his wife, who I haven't seen I've seen, but not been able to sit down with in a while. So, yeah.
Okay. A person has recovered from COVID last year, recently got 2 doses of vaccine, and learned that they have been exposed to a positive person after the second dose, but it was less than 2 weeks after the second dose. Should that person get a COVID test due to the exposure?
That's interesting. So the question is, when do you get a COVID test? Now, this is a person who had COVID and got both injections of the vaccine, right? That's what you said?
Yes.
If I were them, I would wait and just see if symptoms come up. My bet is that person is very highly immune. And I would just monitor my symptoms. I'd isolate and quarantine just to make sure that in case I got infected and I'm expressing virus, but I don't get any symptoms, I'm not infecting somebody else. So I would stay home. I would try to not be around a whole lot of other people. But I don't think they need to get a test. They could. Sometimes we also find that people who have had COVID shed virus, or virus shows up in the test a long time after the symptoms are gone, which is why CDC is not recommending that people get COVID tests after they've had COVID, to show that, you're over it. You're over it when your symptoms say you're over it, but sometimes people are still shedding virus. So the answer is, I would say, you can always get a test, but if it's positive, what does that mean? It means you're shedding virus, but we already know that could be the case. So just be sure to be careful not to shed virus on somebody else if you are, and to monitor yourself for symptoms, which my guess is they're not going to appear because they are immune. They are immune from getting the virus, which was antibodies in response to my whole fist, and they're immune because they got the specific spike. As a matter of fact, the studies show that people who get COVID and get the virus have less immunity or less effective protection than people who get just the vaccine, because the vaccine is focused on this very critical spike protein, whereas if you get infected, you're responding to the whole thing. Does that make sense?
Yes, yes, it does.
Okay.
And I guess I have a comment behind that and a question. I had COVID last year in March. I'll expand a little bit farther. The Jim Dandy Ski Club went to Sun Valley, Idaho last year in the end of February. And we
right at
went there for a week. And there were a good 600 to 1,000 people that we mingled with and had a good time with, partied, had fun. And we came home. And the week after we came home was when all of this, the numbers were rising everywhere. We didn't think anything of it, but then a few days later, we had symptoms. There were a lot of us, most of us were sick with COVID. And in my case, I had symptoms for like 21 days. And when the symptoms were gone, I have gone to my personal physician maybe 3 or 4 times since then. And I asked her to test for antibodies, because originally when I was tested, they said that I was negative and I didn't have COVID, but I had all the symptoms. And when we tested for antibodies, I had antibodies. And I've had antibodies all the way up and through January still.
Great. That's good.
So does that mean that my body is still fighting something, or what does that mean that I have so long?
Thank you for sharing that. That is a terrific insight into a lot of things. First of all, that ski trip where none of us knew that coronavirus was circulating the way it was, because it was already in the US. People thought it was on the West Coast, and it was already entering on the East Coast, and it was here long before we, quote, knew it was here. Second of all, you're getting the symptoms, even though when you were tested, you were negative, meant that our testing at that time wasn't as good as it is now, as well as sometimes we couldn't get in to be tested, right? We didn't have all the criteria that, remember, the tests were limited at the beginning, so it was really hard to get a COVID test. And also, the reason you still have antibodies is because your body saw the virus, the whole virus, and responded as it should and made a memory, which is in antibodies. So the next time you see it, you are those antibodies are going to say, oh, I know that. Let me go in and destroy it. The fact that you got it in March and you still had antibodies in January, that's some of the best news I've heard lately, because that means that you have a response for 9 months to this virus. And that's what we're hoping. That's what the clinical trials are showing now, or testing now. How long does it last? So no, because you have antibodies doesn't mean that you're shedding virus at all. It means that your immune system is working like it should. And you are that's quite a story. I like it. And I go back to that ski resort, that chalet I showed. I should have asked you all just to share your story.
Oh yes, we most people survived. There were a few people in our bigger club, National Brotherhood of Skiers. We had about 4 people who did not survive, but most people did.
And let me just put out, this is a thought. You are skiers. Not everybody can ski, right? You can't have a whole lot of really serious underlying conditions that are not managed in ski. You can have diabetes, but it has to be managed. So you guys are reasonably healthy, I would believe. And so even though a lot of you got exposed, a lot of you survived. And what we're seeing with the high number of deaths among African Americans are the people who are most vulnerable: people with heart disease, people with diabetes, people with COPD and other things that are not managed, people who are very much overweight, such that there's a heavy burden on their lung system. And so these are the very people, as one of my, I was on a podcast recently, and he said, I have heart disease. Why should I get it? And I explained to him, well, you should get it, because if you get coronavirus, it's likely going to be you're one of those people where it could be more severe and even lead to serious illness. And so he said, so you're telling me, Prof, that the people who have the underlying conditions are the ones who need to be front of the line for the vaccine. I'm like, you got it. Those are the people that need to be front of the line for the vaccine. And that's what the wonderful Michigan Department of Health is trying to do by getting vaccines into communities of color, such that where the high levels of severe illness, hospitalizations, and deaths are, we also have access to the vaccines. And other people want to come into our communities because everybody wants a coronavirus vaccine. So we should do this. We should make sure we take advantage of the opportunity to protect ourselves against serious disease, either of ourselves or getting infected and sharing the virus with somebody else, even if we don't have symptoms.
Okay.
I see
Let's
someone
see.
say, I have severe allergies. I'm reluctant right now to get the vaccine because my body is starting to react to everything. Do you have suggestions or recommendations? Can I answer that one?
Sure.
Yeah, so I've heard a lot about if I have allergies, what do I do? And what the CDC and others, even around the world, are showing is that the allergy or the allergic reaction we worry about, and an allergic reaction is simply the body's response, the same immune system saying, oops, there's something here, I'm going to attack it, and it just overdoes it. It's turbocharged, supercharged. And so people who have known allergic reactions when they get a vaccination, so if you've ever had a flu shot or the measles, mumps, rubella, and you had a reaction to that, or you have anaphylactic response, which is what that turbo response is to certain things like peanut butter or nuts or something. Those people usually have an epinephrine pen that they use to inject themselves to shut down the turbocharge, to quiet down the immune system. Those people, unless they have something else that their health provider says don't do it, they should get the vaccine, and they just take their epinephrine pen with them. Most of these people don't have a response, and if they do, that immediate injection can counter it. And so those people with allergies, particularly to vaccines, are asked to remain at the site for 30 minutes to make sure they're fine. And if nothing happens, they're good to go. So a person with severe allergies can get the vaccine, but just be mindful that you want to remain hydrated. You want to do what you would do for your allergies anyway. And adding the vaccine should not complicate that. We're in a season of pollen right now, but you can still get the vaccine. Talk to your health provider.
Okay. Is there any data regarding those who have died, people who were perfectly healthy versus those who had pre-existing conditions? In other words, how many people who had good health have died due to COVID-19?
Yeah, and I don't know the exact answer to that. I know that's a big question with the AstraZeneca vaccine that is in Europe that is not approved here. I do also know there was a reported man in Florida who died of something called thrombocytopenia, I think it is, where your platelets, the platelets are what cause the blood to clot, and his platelets were greatly diminished. He was healthy, he got the vaccine, and then some like 12 days after, he died of thrombocytopenia. But there have been so few deaths that can be in any way associated with the vaccine. And I've even seen circulating on Facebook, you have all these videos and experts on things. There's one video from a health provider who says that in the clinical trials, people actually died from the vaccine. So therefore you shouldn't get the vaccine, right? Because people die from it. But what that person missed or isn't telling you is that if you have over 70,000 people in a trial for at least 4 months, which was required, some people are likely to die out of 70,000 people over 4 months, don't you think? And some of those had underlying symptoms. And what that person didn't say is that the people that got vaccine didn't die any more than the people that got the placebo. So people both who got the sugar water and people who got the vaccine, a few of them, I think it was something like 12 or 18 or something total in that time, maybe even less than that, 4 or 6. I can't remember the numbers, but they were evenly distributed. They were not more in the vaccine than in the placebo. And if you think about that, if it was the vaccine that was the causative agent, you would expect to have more deaths in the vaccine group. But that person had done their research, but they didn't tell you that deaths were in both groups. And so it's misleading what they were saying, that the vaccine causes death. So to answer your question, when there have been severe issues, even severe issues with the vaccine, they're in a very, very small percentage of people. And I'll also tell you, I was concerned about that when we were at the review. But what has happened since then, by people reporting symptoms to the Be Safe, we see what's actually happening in the rollout compared to what happened with the 70,000 people in the vaccine trials. And we're seeing the very same things. For most people, there is not a severe reaction. For most people, there have not been an adverse event. The side effects are what they said they would be. The time the side effects last is for 2 to 3 days, like they said. So that gave me a lot more confidence that the clinical studies really mirror what happens in real life. And so with that information in hand, I went and got my vaccine or got a vaccine, and I'm very glad that I did.
Okay. Here's one about nursing children. How are nursing children affected by the vaccine? Should they take the vaccine while nursing?
Yeah, I was on a webinar with a group in Maryland, and there was an OBGYN physician there. And so questions came up about pregnancy and nursing. So it turns out that women who get COVID because they're not vaccinated have a very serious issue because the immune system, I didn't know this, but the immune system apparently is less robust if you're pregnant. And that makes sense because you're carrying a baby and you don't want your immune system to recognize the baby as foreign. So it's down some. And so that leaves you very vulnerable to a disease from coronavirus infection. And so it turns out that if you get vaccinated, that protects the mother from getting infected. And it turns out recent studies are showing that the antibodies that the mother makes from the vaccine, some of them are transferred to the child in the breast milk. Like, you can have what's called maternal antibody transfer, maternal passive transfer that protects the child before the child's immune system comes up. That seems to be happening also with the coronavirus vaccine antibodies. So for a pregnant woman or even a person who is breastfeeding, it's actually positive to get a vaccine to protect the person. Obviously, you don't want the mother to get COVID, but when her body responds by making immune protection and antibodies, those can be transferred to the child.
Okay. Aren't we still a part of trials? How can you squeeze 4 to 10 years of research outcome into a few months? How can anyone know the side effects 4 to 10 years from now?
We are still doing clinical trials. So all 3 of these companies, as I think I said, they do not have a FDA license. They are all using emergency use authorization because we are in a crisis where people are dying. So we don't know the long-term effects. We cannot know because we haven't had the vaccines. They went through the same procedure that vaccines normally do. It's just that because it was a shorter time, it had to be done in a larger number of people. And so you get the same power, you get the same proof of principle if you have 3,000 people for 5 years as you do if you have 30,000 people for 4 months in terms of the statistical data. But what we cannot know because we haven't done it is what happens in 3 years or 5 years. And that's what I said, where I was like, okay, I don't want to get coronavirus. I don't want to get COVID. And even if I don't get sick, I don't want to give it to somebody else because the virus is reproducing in me. I also don't want to be a test tube, if you will, for the variants to come up and change in me. The more we let the virus replicates, the more chance we have of new variants that could get even worse than what we have now. So we cannot possibly know 3 to 5 years from now because we can't do that. We just don't know. And I don't think we can wait. The vaccines will have to, they're continuing to do studies, like there's studies underway now to ask how long does immunity last. I actually signed up for one to look at my antibody levels from now forward. But you've already done that experiment. You and your health provider already did that with COVID. And I like your results that if you got infected in late February or March and you still have antibodies in January, that's really cool. So we don't know. So what am I saying? I'm saying we can't possibly know the long-term effects. And that may be the one thing that we can't tell somebody. But we can tell someone COVID-19 is dangerous to either you or somebody you take it to. The vaccines protect against disease, and it looks like they're protecting against at least some shedding. People who have the early studies are showing that people who have vaccines are putting out less virus should they get exposed than people who don't have the vaccine.
Okay. This is a pretty interesting question. I heard if someone contracts the virus after the first dose, they cannot get the second dose. If this is true, does that mean that when they're well again, they have to start the process over again?
You know, I don't know the answer to that. They can't get the second dose while they're infected with COVID. You really have to wait several weeks till after your symptoms are all gone before you get a vaccination, right? So I've heard someone say that he got the first dose, got COVID, and then he was told that he had to start all over again. But then I've also heard people say, no, you just wait a period of time and you get your second dose. You don't need 2 more doses. So I think you really have to consult your own health provider about that. The whole point is that you get immunity from having COVID, some. You also get immunity from having the vaccine, and you get the best immunity from having 2 doses of the Moderna and Pfizer vaccine. So, and this is also known that people who have COVID, when they get the vaccine, they often have a more robust side effects than people who've never had COVID. If I may ask, did you get the vaccine yet?
I had my first dose. I'll take the second next week. I took the Pfizer.
And what if I could ask, what were the side effects?
I had a sore arm, and like you said, I had a little weight and I was working the muscle in the arm, but it still was very sore for about 3 or 4 days.
Okay.
But I took the vaccination at 11:30 in the morning. By 7 that evening, I started feeling chills, and I got a headache, and I was kind of tired. So I was just kind of down for the count for the rest of the day. And the next day I was tired, but no headache and chills the next day, just body aches a little bit. And that was it.
And by the 3rd day, were most of those symptoms gone, except maybe a little bit of soreness in the arm?
Except the arm. The rest, the other symptoms were gone.
So that's a classic example of the side effects. And you had COVID, so yours were maybe a little bit more than someone who had never been exposed before. And all of those things were because your immune system is working well. Just remember that those side effects are due to the effects of the immune system doing what it's supposed to do to prepare you such that if you see this thing again, you can knock it out before it ever really catches hold.
Okay. If your shot is with Pfizer, can you get your second shot of Moderna?
The recommendation is no. If you start with Pfizer, do Pfizer. If you do Moderna, do Moderna. And that's because there's some slight difference in formulation. And also it helps to follow the clinical trial protocol. So we would recommend that you stay with the same one.
Okay.
I do know, however, some people say, well, what if I can't get back in 21 days with Pfizer, 28 days with Moderna? Get it as soon as you can. Get the second one as soon as you can.
Okay. A physician friend mentioned that in research he is doing regarding higher incidences of prostate cancer in African-American men, pro-inflammatory cytokines are showing genetically to be a major contributor. he stated that it is looking like this may also be a factor in higher negative consequences regarding lung function with COVID in African Americans. Are you aware of any direct genetic research regarding the higher incidence of COVID in African Americans?
I am not directly. I remember there was some genetic analyses being done early on, which suggested that some people with a certain blood type, I think it was O positive blood type, might be less likely to get infected. But I honestly have not kept up with the genetic predisposition studies. And I, as far as I know, there's nothing that's solid at the moment. There's lots and lots and lots of research going on.
Okay. I've had both Moderna injections, the last one on April 4th. My question, why am I always tired and ready to sleep whenever I sit down? Today is the 8th. Yes.
Yep. I think one, because your body has been really using energy to respond to this vaccine. I was tired too. I was very, very tired. Even like around the 10th day, I had a period of like, I am so exhausted. And I thought, is it my schedule? Because, my schedule isn't really simple. But I think it's just that your body is revving up. It's making all these protein, which is what the antibodies are made of. So you're using energy that you normally would have for other things. And the body says, gosh, I need to rest, or I can't support all this internal activity going on. So I think if the second injection was just April 4th, that they're probably still responding. Hopefully they're still responding and mounting that protective immune response. I see a question about how did you vote for different vaccines? May I answer that one because it's easy?
Yes.
So the first one was Pfizer, and all of this was done virtually. So we were not in the room. We were kind of like we are today, and we could only actually see the person that we couldn't even see the other panelists. We did not get to ask some of the questions I thought were most important, like, does it protect against infection? How long does the immunity last? Those questions didn't come up. And so for the Pfizer one, we were also told that we would get to explain our vote at the end of the voting process. And so I thought, okay, the discussion was around whether it should be given to 16-year-olds. And the question in all of these was, are the risk of the disease greater than the risk of the vaccine? And if you thought the risk of the disease is greater than the risk of the vaccine, and you turn that question around, is the risk of the vaccine higher than the risk of the disease? So I said for Pfizer, I don't know. I'm not ready to approve this yet because it's going to go into millions of arms if we do say yes. And I need some more answers. I need to understand a few more things. I didn't even get to ask, are you doing those experiments? It would have been okay with me if they said, well, we don't know, we're doing those experiments. At least they knew the issue was there. So to answer the question, I voted no, and my no was no, not yet for Pfizer. Let's learn a few more things. Let's give it to our physicians and healthcare providers. Let's use it to protect our most vulnerable residential home citizens, but within the clinical trial before we approve it for widespread rollout into millions of people. So I said no for Pfizer because of lack of information. I wasn't ready. Me and 3 other people voted no. By the time Moderna came around, the FDA had changed the procedure of review. They'd given us much more time to ask questions. They had given us some different instructions about how to get in line to ask the questions virtually. And so when Moderna came up a week later, we had so much more information. There was so much more transparency. They said, we're doing these experiments, but we don't know the answers. We're going to check about whether they're shedding. So I voted yes for Moderna. And then, of course, when Johnson & Johnson came along, we were well into the vaccine rollout. And this was a 1-dose vaccine that had been tested in a higher number of people of color around the world. It was 100% effective against death. It was highly effective against severe infections of COVID. And so I voted yes. I was like, yes, we need this, because also Pfizer had to be super cold, as you know. Moderna was less super cold. And then J&J, I'm told, can be fine in the refrigerator for 3 months. So that means it can go into those very difficult places like the Kalahari Desert where I've worked, or Zambia, or rural Alabama, or some places where you may not have access to the low temperature freezers. So I was very much yes for Johnson & Johnson. So the panel also was unanimously yes for Johnson & Johnson, unanimously yes for Moderna, and 4 no's and 17 yeses for Pfizer because it was the first one.
This is an interesting one. If you have no side effects, does it mean I don't have good immunity?
No, it means that you just did not have the side effects. And the only way to know is to get an antibody test and see what you got. But a lot of people have no side effects. For my second vaccine injection, I had no side effects, surprisingly.
So if they got an antibody test, I don't understand. What would that show them?
Yes, that would show what the level of your specific antibodies to spike protein is. And that's what you want. You want those to be high. Okay. And so the COVID-19 test looks for viral genetic material. But if you're looking at a serum or blood test, you're looking for how has your immune system ever seen this and made a response? And 2, how good is that response?
Okay. And I have a couple of questions that have been texted to me.
We're almost about at the end of our time. So we have 3 more minutes if we want to honor people's time here. I can go on, but it's up to you. You guys are hosting it.
Okay, well, if you're willing to stay, then I would say that anybody else who wants to stay on, and we can stay on for maybe another 15 minutes, maybe.
Well, let's go. Let's see what we got for another 5 minutes. Let's see what happens.
Okay.
I'm just aware of people's. We have 94 people still. Wow, that's amazing. Okay, let's do it.
Okay. How long does the vaccine last? What happens after that time period? Oh, I'm sorry, that's the repeat. What is the rash about at the site of the injection after getting vaccine?
Yeah, I've seen that. Actually, one of our daughters just got the Pfizer, and she showed me a picture where there's a little red area around the injection site. And so I think that is just a response that some people have to skin antigens or antigens at the site where there's something foreign there. I had another friend whose circle, she has a peanut allergy. She took her epinephrine pin with her to the vaccine, but like 5 days later, she showed us this huge circle on her arm that was like bigger than a baseball, Mm-hmm. So I think that's some people, some people have different skin, have very sensitive skin. Actually, the daughter that did this has always had really sensitive skin. So she's, how some people can't, certain soaps will irritate their skin. She's like that. So she had a very small area around the injection.
Okay. My daughter has an autoimmune disease called antisynthetase syndrome. It is a rare myositis disease that affects the lungs, skin, joints, and muscles. She's reluctant to get vaccinated. What advice could I share with her?
I would simply say she really, I assume the daughter is an adult, needs to talk with her health provider about what is the best plan for her, how to have her known condition managed, so that should it be advisable for her to get a vaccine, that will be the case. I unfortunately cannot make any recommendations except that she talk very closely with a health provider that she trusts.
Okay. Patient is bed bound and homebound. Is there a way that vaccine can be brought to their home?
I think there is. I would get in touch with the Washtenaw, or not Washtenaw, whatever county health department, and explain the situation. I've seen that happening in some cases where people were homebound, that the vaccine mobile units can come to their home.
Okay. Patient has had a flu and pneumonia vaccine in the past week. How long should they wait before they get the COVID vaccine?
Yeah, the guidelines are suggesting that you should wait at least 14 to 21 days after you get another vaccine before you get the COVID-19, just to give your immune system a chance to recover from the other vaccine. I would definitely do 14, if not a little bit longer time. And again, that's something you can talk to a health provider about.
Okay. Okay. If you have no symptoms of COVID, should you still be tested? That's kind of general.
Only if you know you've had an exposure. So let's say you're around someone who tested positive and you knew you were around that person and they've either tested positive or they've gotten COVID, I would get a test. Tests are much easier to get these days than they used to be. Yeah, why not?
All right. Okay. I think we've covered all of the questions in the chat.
So if I see this last one, if you have no symptoms of COVID and you've never had any exposures, then I don't think you need to be tested, right? But if you had potential exposure, then you should get it. And even if you just want to know, do it. Tests are not that difficult to get these days. I think we've had a wonderful discussion. I'm really impressed with the number of people, the number of questions, the quality or the level of curiosity and what people want to know. I'm thrilled. I'm like, wow, this was good. I hope I've been helpful.
You have. And I'm wondering what you would have to say to people who are skeptical about taking the vaccine because they're concerned about what the data will be used for. Is the government collecting the data, and do you have to allow them to collect the data? Because there's some people who they don't want to take the shot because they don't want people collecting information on them.
You can get the vaccine without being part of Be Safe or any other info except that you got the vaccine. That's all. I've heard people say, well, the vaccine, there's a video that says it puts a video microchip in your arm and people can download information. I mean, these are all part of the conspiracy theories that are going around. But Janice, when we carry our cell phone around, people can tell what things you like, what things you don't like. I mean, it's amazing what we give away in just having a cell phone. So I don't think that we need to worry about these vaccines allowing the government to do anything for us that we're not already allowing the government to do, and anybody else, any advertising companies to do with our cell phone information.
Okay. And I really appreciate you coming to speak with us, and it's been very, very interesting. I like your presentation, and looking forward to watching the video again so that I can see what I missed.
I understand when you're in it, you just need to go back and look at it so you can observe and be part of it. And you've been a great host. These questions have been tremendous. In closing, I just want to say to people that one way that I like to think about this, and someone helped me understand that 3 to 5 years from now, most of us are going to have some immunity to coronavirus. And it's either going to come from getting COVID and surviving like you did.
Yes.
But some people may not survive depending on, how fortunate and how much virus they get. Or they're going to have immunity from a vaccine. And of those two options, getting the vaccine is the much less risky one, because we do want immunity to protect ourselves and to protect others. People who say, well, it's my personal freedom not to wear a mask and it's my personal freedom not to get a vaccine. I think that's true, but we live in a world where we're interconnected, and we do need to be our brothers and our sisters' keeper, not only in the US, but globally. We won't get past COVID until we get past COVID together. And the other thing I'd like to say is that we need to work collectively to shut down the pandemic such that we don't get to much more difficult variants to handle. What's the end game? The end game is probably going to be where we coexist with coronavirus, with COVID-19, like we coexist with influenza. And when the levels of positive tests are below 3% in a region or in a community, so let's say Metro Detroit and Wayne County and Oakland and Washtenaw County, we will be able to have our schools open. We'll be able to go to concerts and movies and have events at our families and maybe even our churches. And as long as it's below 3%, that means that if somebody gets COVID, we can do contact tracing and we can follow it, quarantine people such that it's not going wild. If it does go above that 3 to 5%, that means we might have to all don masks again. That's probably that's one scenario of what's going to happen. The other scenario is that we'll be able to shut this down far enough that the virus doesn't even mutate to be able to have a form that continues to go. And that would be really great. But at the worst, I think the end game is that we will learn to coexist with coronavirus without the deaths and severe illness and suffering. So many people have lost loved ones, lost jobs, lost schooling time. There's been a lot of loss in this pandemic. A lot of it, I'll just say, I believe could have been avoided, but we too have to bear some of that responsibility because we didn't always do the masking and the distancing and the staying home and the washing our hands. We can do better. And I believe with the vaccine as a tool in the toolkit, 3 of them, with the preventions that we have, with how much we've learned about the disease and the virus, with lots more to learn, that we can really manage this pandemic and get a reasonable level of life back. I'm looking forward to gathering with my friends and with my children and traveling again and maybe going with you guys skiing.
Yeah, you should
What
come.
a thought.
Yes.
The 2 or 3 times I was on skis, I realized, you know what, this might not be for you.
Well, you can come out and watch us and have a snack or a drink in the bar and look outside and watch us ski.
I'll enjoy your enjoying it. How about that? Maybe you can teach me to ski.
Yes, maybe I can. I'd be honored to try and teach you to ski. And I want Ethel to mention our partners. Ethel, can you unmute yourself?
Yes.
Ethel was responsible for pulling all this together, and she pushed me along. And I worked with Ethel, and we were able to bring 146 people registered for this. And I saw about 97 maximum online today. And so, Ethel, would you like to speak on your invitations to our supporting groups?
Yes, I want to say thank you to Janice and the Jim Dandy Ski Club for hosting this presentation. Thanks to Dr. Fuller for agreeing to give us, we know how precious your time is. And yes, you can learn how to ski. The reason you thought that it wasn't for you before is because you didn't have the Jim Dandy Ski Club behind you. They're good for teaching you things. But I also want to say thanks to our partners, the Fred Hart Williams Genealogical Society, the Detroit Association of Black Storytellers, and the AKAs were groups who decided that this information is important enough for us to partner together to bring to our community. So thank you again, and we would love to have you come back and tell us more after you get the answers to those other questions that you have. But you had also mentioned that there is a panel discussion where people will be able to just ask. It's just a question and answer session on tomorrow. Is that open for some people who didn't get all their questions answered tonight?
Absolutely. The American Society of Virology, which is scientists with viruses, are sponsoring a series called Talk to Me. So if you Google Talk to Me, I'm doing one with Dr. Webster from University of North Carolina, an African-American sister that I know well, tomorrow night. And we're targeting, really, we want young adults and people who love them to be on, because as the states open up to make the vaccines now available to anyone 16 and above, Pfizer 16 and the other two 18 and above, we want to be sure that young adults and those in the middle ages are getting vaccines, and they may have different questions. So we targeted for Friday night at 8 o'clock. We're calling it the Friday Night Talk to Me Jam. And so, yes, people can Google that. I can't put the information in the chat, but maybe you guys can send it out to your networks, and we would love, it's open, it's wide open. We could have 500 people on there. I don't think it'll be 500, but there's no limit to the number of people. So that's tomorrow night at 8 o'clock Eastern Daylight Savings Time.
Also, you talked about trusted messengers. I still didn't get a site so that I can make a donation. And there might be others who want to make donations.
I will talk to you about that. Trusted Messenger is a team that we have now. As I retire from Michigan sometime in the near future, it will be a consulting or nonprofit where we continue to do these sorts of things, but because I'll be retired, we'll need another banner to do them under. But you can get in touch with me at trustmessengers@gmail.com, and I can answer any of those questions for anyone who wants to make a contribution. Trust Messengers, TRUSTMESSENGERS @gmail.com.
Okay, thank you very much. And thanks again. Janice.
Everybody be well. Remember that we're in this together. What you do for you is also for your neighbor. We are in this thing together, and hopefully we'll get through it together. Thank you so much. It's been fun.
Thank you. Thank you again. And I will reach out to everyone. I have everyone's email so that you can have a link to this, to the video that's being recorded so that you can share it as much as you want, and so look at it for yourself. And thanks again so much.
Have a good night. Stay well.